Thank the organizers for inviting me to give this presentation. I'd like to thank all of you for coming in bright and early. How do I move forward? Oh, sorry. Okay. So I'm going to divide this talk into really two main parts. So I'm initially going to give you my own views on individualization of vascular access, and I'm going to do this at the level of the health professional, at the national quality level, and at the patient and patient preference level. And then in the second part of this presentation, I'm actually going to use this information to tell you about my own personal vision in many ways for a future combinatorial approach to vascular access individualization, which really merges clinical and biological predictors with novel technologies. So let's initially talk about individualization at the health professional level. So you've got a 75-year-old woman who presents to you for a new vascular access. She's got an arterial diameter of just over 2 millimeters at the wrist, a venous diameter of just under 3 millimeters at the wrist and at the elbow. So what are our options in this patient? And I think most of you in this room would agree that the right answer for this question is that we really do need more information. And the reason we need more information is that this 75-year-old woman could go down a number of different scenarios. So let's suppose that she was actually a preemptive CKD patient, plenty of time for the fistula to mature before she gets onto dialysis, and with minimal comorbidities. The correct answer for her individualization of vascular access is clearly an AV fistula. On the other hand, if you make this to be a woman who's got multiple comorbidities, who's been on dialysis for 4 years, who's had a tunnel dialysis catheter for 6 months and has had 2 catheter infections during that period of time, and who's also had 2 previous failed accesses, then suddenly a fistula doesn't seem that good of an idea, and perhaps this patient should actually get an AV graft. And then if you take this scenario and you add into this a previous history of steel requiring amputation and multi-infarct dementia with the patient in a nursing home, then suddenly neither a fistula nor a graft seems such a good idea, and maybe the correct sort of access for this patient is actually a tunnel dialysis catheter. So that's at the health professional level. What about at the national quality care level? Now, the panel on the left describes to you AV fistula prevalence rates in different countries from the DOPS study between 1996 and 2007. And I would make the case to you that if, in fact, we were in the United States in 1996 with a 24% AV fistula prevalence rate, that the right approach would, in fact, be a one-size-fits-all fistula-first approach. On the other hand, if we are where we are now with a fistula prevalence rate of over 60%, then perhaps